Uh, Good morning. We will start now, and the grand round today is by the Department of Clinical Hematology, and they have chosen a very useful topic and sometimes a perplexing topic, and that is monoclonal gammopathies or plasma cell disorders. And truly, they present with a very wide spectrum, and they will probably tell us also how we should evaluate these patients and manage them. Thank you. Sanjeev, please start.
Good morning, everyone. On behalf of Department of Hematology, I welcome you all. In today's clinical grand round, we will present monoclonal gammopathies or plasma cell disorders, the clinician Enigma. First of all, we present some cases. After that, we will discuss about the disorder. I welcome Dr. Nihar for clinical case presentations.
Good morning, respected faculty members and my colleagues. And thank you, Dr. Sanjeev, for this opportunity. So I'll be starting with the first half of the clinical grand round. And we'll begin with the first case for the day. We had a 38-year-old male who was referred from a general practitioner to the Department of Neurology at our institute for evaluation of tingling numbness of his bilateral lower limbs of 2 months duration. The patient also noted to have some skin darkening, which had started a few months before that, total duration being 3 months. He quantified his weight loss as approximately 6 kg over the past 2 months. And when he started developing some dyspnea on exertion, that's when he reported to the institute. As we can see in this clinical image, the patient had some diffuse hyperpigmentation and clubbing, digital clubbing. On clinical examination, when it was done by the neurology colleagues, they found that the patient had digital clubbing as seen in the image and a generalized hyperpigmentation more marked over the trunk. On doing a nervous system examination, they noted the cranial nerves to be normal. The power in the lower limbs was reduced, as well as the upper limbs being 3/5, and conspicuously bilateral knee and ankle jerks were absent. Plantar examination, both were flexor, as well as the sensory examination was completely within normal limits. So the patient was then referred to us when the patient was noted to have a thrombocytosis on a routine blood examination. So in keeping, we worked up, we had a working diagnosis of some underlying disorder which was having a systemic onset because of a generalized hyperpigmentation. He had clubbing and a thrombocytosis. We were leaning towards diagnosis of some monoclonal gammopathy could be at play here. So we asked for a bone marrow examination and a protein electrophoresis, which revealed a lambda light chain of 0.9 grams per deciliter with a deranged free light chain ratio. And the bone marrow examination showed 6 to 8% of clonal plasma cells, which were highlighted on IHC for CD138. So putting this all together, a diagnosis of Poem syndrome was reached, wherein the patient fulfilled both the mandatory criteria, that is, the patient had a polyneuropathy and a monoclonal plasma cell clone, and also fulfilled some of the other minor as well as the major criteria. The patient was started on clone-based therapy, as is the norm for these disorders. He received a triplet induction regimen comprising of bortezomib, cyclophosphamide, and dexamethasone, and followed by lenalidomide maintenance. The patient is 2 years into follow-up now and remains on lenalidomide maintenance with almost complete resolution of his polyneuropathy, and the patient is back to his routine work. The second case for the day is also quite interesting, and it was referred to us by our neurosurgery colleagues. The patient was under their follow-up when she presented with left-sided focal seizures without any loss of consciousness and behavioral changes spanning 3 weeks. This prompted imaging of the CNS, and it revealed a mass lesion in the false cerebri, and a suspected diagnosis of meningioma was made. However, on a preoperative workup, the neurosurgeons found that there was anemia and thrombocytopenia, and thus we were called in for a consult. When we noted the complete blood counts, there was something which was quite intriguing, and there were 22% abnormal cells which were noted. However, when we evaluated in our laboratory, we found that those were 22% abnormal plasma cells. And there was, as pointed out, there was anemia as well as a significant thrombocytopenia. Further investigations revealed that the patient had significant hypercalcemia with a calcium level of 13.2 and a serum creatinine of 3.4 milligram per deciliter, which was new onset, making it a diagnosis of AKI. This led to a bone marrow examination because there was a strong suspicion of an underlying plasma cell disorder given the circulating plasma cells, and the bone marrow revealed 66% atypical plasma cells, and immunofixation electrophoresis revealed a IgG kappa light chain and a monoclonal band of 5.2 gram per deciliter. Typical punched out lesions as is the norm in multiple myeloma on a skeletal survey was noted. There were also lytic lesions found when we did other skeletal surveys, including imaging for the dorsolumbar vertebrae and the ribs. So the diagnosis was a plasma cell leukemia with CNS involvement, wherein the patient presented with seizures to the Department of Neurosurgery. So the patient had more than 2000 per microliter of plasma cells, or 20% of the peripheral blood white cell percentage. And the treatment received was again a triplet induction regimen comprising of bortezomib, lenalidomide, and dexamethasone. The third case for the day is that of a 55-year-old gentleman being evaluated by our nephrology colleagues in view of increasing breathlessness for 2 months, signs of fluid overload, and oliguria for the last 5 days. On being evaluated, they found that on a urine analysis, the patient had a significant proteinuria with a 24-hour urine protein of 1.8 grams. The creatinine was elevated 2.59 milligram per deciliter. And the patient on further history had a history of hypertension spanning 20 years, was a known hypothyroid on 75 micrograms replacement dose, had a history of obstructive sleep apnea syndrome, and also presented with an active urinary tract infection. In view of on working up for the underlying cause of the renal injury, because on ultrasound examination the patient had normal sized kidneys, since we have a close working relationship with our nephrology colleagues, they asked us to work up for a possibility of an underlying plasma cell disorder. And again, when we did a free light chain assay, we found it to be significantly deranged. Although the routine investigations like M protein that we do routinely, serum protein electrophoresis and immunofixation, did not reveal a clone. But however, the light chain assay did pick up a kappa clone of kappa light chain burden of 1200 milligram per deciliter. The PET CT, which was done subsequently to rule out if there was any extramedullary disease or any plasmacytomas, revealed no lytic lesions or extramedullary diseases. And then we went ahead with a bone marrow examination, which revealed 6% clonal plasma cells with an otherwise age-appropriate cellularity. These are the images from the patient's kidney biopsy, native kidney biopsy, which reveals a nodular glomerulosclerosis. And this is the electron microscopic images, which is we're thankful to the Department of Pathology for the same, which reveals subendothelial amorphous deposits. This helped us clinch the diagnosis of a monoclonal immunoglobulin deposition disease, or MIDD, which is a new entity which fits into the umbrella term of monoclonal gammopathies of renal significance. Thus, it's important to note that an investigation like a serum-free light chain and then subsequently a biopsy helped us clinch the diagnosis in this otherwise little complex case. The norm in these patients again is to give clone-directed therapy rather than any other form of immunosuppression. So the patient received 4 cycles of a triplet induction regimen, bortezomib being the backbone, combined with cyclophosphamide and dexamethasone, and now is in a very good partial response. So as we have seen thus far, that a single disease can have multi-system presentations and at times variable manifestations spanning many systems together. And with this, I'd like to call in my senior colleague, Dr. Fahima, who will take over.
Good morning, everyone. We'll just delve into a short history of this prototype of monoclonal gammopathies, myeloma. It is not a new disease. It has been reported as early as 200 AD by paleontologists in American Indian skeletons. The first published case, however, and the well-read case is that of Sarah Newberry, a 39-year-old female who presented in 1840. There was no treatment available, and what she received was an array of exotic herbs, the then foods available, which was luxury foods, and even wine and opiates. And she succumbed to her illness within 4 years of diagnosis. And within 2 months of her demise, Samuel Soley published it in Medico-Chirurgical Transaction with these images, which shows a fracture of humerus, bilateral femur, and a picture of her femur showing destruction of the bone. So what exactly are monoclonal gammopathies? So they are a spectrum of disorder which is characterized by the presence of a monoclonal immunoglobulin, which can be seen in plasma, urine, or both, which are produced by clonal plasma cells mostly and less commonly by B lymphocytes. The presentation may have an end organ damage like the one we see in myeloma and Waldenstrom's, or it can be without an end organ damage, which I'm going to talk about in a few minutes. So what are this distribution of monoclonal gammopathies? The most well-studied cohort comes from Dr. Kyle, the father of myeloma, with a series of 56,391 cases. So 57% of the monoclonal gammopathies was MGUS. What MGUS is? Monoclonal gammopathy of undetermined significance, and it has a prevalence of 3% of general populations in above 50 years and up to 5% in over 70 years. And the next common one was that of myeloma, with an incidence of 3 to 9 cases per 100,000 population per year, to be immediately followed by AL amyloidosis, the lymphoproliferative disorders, which can be due to the less common B-cell clone, immediately followed by SMM or smoldering myeloma, and then by Waldenstrom's macroglobulinemia. So how does this transition come from monoclonal gammopathy of undetermined significance and transform into myeloma? As we said, it's a spectrum of the disease. There are these post-germinal center B cells, which undergoes multiple in-cells, majority of which are not understood, but recurrent infections, genetic predilections, and race seems to be one of the causes. And they undergo primary genetic events in the form of IgH translocations and hyperdiploidy. And as time goes, the secondary hit happens in these MGUS clonal plasma cells, which has not yet become malignant, in the form of KRAS, c-MYC mutations, and DNA hypomethylations. So what is smoldering multiple myeloma? It's just smoldering. It's becoming a smoke from the non-malignant plasma cells to become the malignant plasma cells of myeloma. And then you have the disease manifestations in the form of crab features, which we are all well aware, and then the disease further progresses into plasma cell leukemia and extramedullary plasmacytomas. How do the labs see it? What is the spectrum and what happens? So now I have shown you here, in teal blue is a normal protein electrophoresis. The one in yellow are the rising titers of the M protein with no end organ damage, giving the so-called picture of a monoclonal gammopathy of undetermined significance. And then the M protein seems to increase in concentration and starts to smolder to become the smoldering myeloma. And it increases in concentration, and the tumor mass also increase, causing mass effects resulting in the clinical manifestations of multiple myeloma. So what are the criteria for the diagnosis of monoclonal gammopathy of undetermined significance and smoldering myeloma? Is the plasma cells do not meet the criteria of the myeloma, that the clonal plasma cells are less than 10%, and there are no myeloma defining events. So the latest criteria for myeloma was updated in 2014 after the Salmon-Dury criteria, which was quite there for a long time. What is new in this 2014 criteria was there was no M-band concentration. Any amount of M-band was enough for diagnosing this, and even no M-band was also accepted because there was this concept of non-secretory myeloma. And then we have the well-established crab features. So this was there for years together. But what was new was the introduction of the SLIM criteria. What the researchers found that even in the subset of patients with smoldering myeloma, which did not meet the criteria of multiple myeloma, these patients had a very high risk of transformation to the disease, and when they transformed, the disease was more severe and more aggressive. So this is a SLIM criteria. S standing for more than 60% of clonal marrow cells, Li standing for the light chain involvement ratio of more than 100, and M for the focal lesion on MRI studies. So what are the clinical manifestations of myeloma and other monoclonal gammopathies? We are well aware of the CRAB features with hypercalcemia, renal impairment, anemia, and the lytic bone lesions. However, what we also saw through these years was that these plasma cells, even when they are not meeting the criteria of myeloma, were causing an array of clinical disorders and varied presentations. They were causing cutaneous manifestations. They were causing renal manifestations. They were causing hyperviscosity, coagulopathy, neuropathy, cold agglutinin disease. But these were not explained by the defining events of myeloma. So, is MGUS the right terminology? These were not fitting into the criteria of SMM, but still fit into the criteria of MGUS. If you see, even our case 1 and case 3 did not have the criteria that fulfill myeloma diagnosis. So is this undetermined terminology the right one to use, or is this a misnomer? So MGUS, we know, over these years is no longer undetermined or insignificant. There are an array of disorders starting from AL, amyloidosis, POEMS, Canomat, cryoglobulinemia to Tempe syndrome, which still fits into the criteria of MGUS and has end organ damage, which may not be myeloma defining events. So the first set of clinicians to notice this was the nephrologists. So in 2012, the term MGRS was introduced by the International Kidney and Monoclonal Gammopathy Research Group. MGRS stands for Monoclonal Gammopathy of Renal Significance, where they saw patients with MGUS, which is very prevalent in patients over 50 years of age, 3% prevalence. So they had a spectrum of renal diseases which did not fulfill the criteria or the pathology of cask nephropathy, but still had an underlying B cell or a plasma cell clone that did not cause tumor complications of myeloma, and one or more kidney lesions that are related to the produced monoclonal immunoglobulin. We saw the case 3, which was an MIDD, which was one of the spectrum of this MGRS. In 2018, we also noticed that not only the kidneys, but the skin and the peripheral nervous system was also significantly involved in these patients with MGUS. So then the novel concept of monoclonal gammopathy of clinical significance was introduced, because the skin, the nervous system, and the kidneys seem to be the primary targets of these monoclonal gammopathies. So what exactly is monoclonal gammopathy of clinical significance? We have these clonal plasma cells which are not yet malignant, and they produce our M protein. So because of the deposition of this M protein, which is causing aggregates immune complexes, or these M proteins causing an autoantibody against a tissue antigen, or in some cases, even the small amount of the B cell clone producing cytokines, there was disease manifestations causing organ dysfunction. So thereby this was called as monoclonal gammopathy of clinical significance. So there are also instances where by unknown mechanisms these clinical manifestations was caused, like that in Tempe syndrome, which stands for telangiectasias and M protein, erythrocytosis, perinephric fluid collection, and intrapulmonary shunting. We don't know the pathophysiology behind these. And so is Schnitzler syndrome, which is a chronic urticaria with an M protein. So do we treat these? We did see that the case 1, which was POEMS syndrome, and the case 3, which was MGRS, warranted therapy. In cases of MGRS, we also noted that if we are not giving a clone-directed therapy, and even after renal transplants, the disease is recurring. So it is very imperative that these B cell clones are targeted and treated based on whether it's a plasma cell clone or a B cell clone. The same applies for MGCS also. The clone-directed therapy is very effective. And even IVIG and rituximab and anti-IL-1 antibodies, especially in those lesions caused by cytokine production, are very useful. However, the physician should strive to assign causality before proceeding with clone-directed therapy. So when a patient with a monoclonal protein not meeting the criteria for myeloma presents to us with a varied neurological or skin manifestations, the first and foremost thing we should do is a clinical examination, and also followed by a serum protein electrophoresis and an SFLC to quantify the protein and to monitor them every 6 monthly for disease progression. So now we'll present the experience of us from 2016 to 2021 with this mysterious and enigmatic disease. I invite my junior colleague Dr. Gopinathan to proceed.
Thank you, Dr. Faima. As my senior colleague Dr. Faima had said, monoclonal gammopathies encompass a wide spectrum of disorder ranging from an asymptomatic presentation like MGUS to a very aggressive presentation like a plasma cell leukemia. So since we being a tertiary institute, we actually see the tip of the iceberg of those monoclonal disorders, wherein patient either presented to our department primarily or they are acquired via interdisciplinary referrals to other common treating departments like nephrology, neuromedicine, and radiotherapy. So one could commonly see here, multiple myeloma is the most common disorder that we commonly encounter in our department, followed by Waldenstrom's macroglobulinemia, solitary plasmacytoma, either with and without marrow involvement, and OM syndrome and plasma cell leukemia contributed to the least of those cases. So coming to the clinical profile of multiple myeloma, we had almost 381 cases who are being treated in our department for the last 5 years, where the median age of presentation is 54 years, which is almost a decade lower than those represented in the Western population. It was predominated by a male predominance and anemia and bone pain being the most common manifestation. Renal impairment was seen in about 60% of those patients, and neurological impairment was seen in almost 13.9% of those patients with peripheral neurological involvement, either in the form of a compressive myelopathy via plasmacytoma or an autoimmune or immune deposition phenomenon via poems and amyloid contributed to the minority of those cases. In contrary to other acute leukemias where CNS is involved as a part and parcel of the disease at the initial presentation, involvement of central nervous system in multiple myeloma is in a very minority of cases and typically tends to involve at a later course of disease time, where typically the plasma cells lose their adhesion and enhance and acquire enhanced survival capability. Extramedullary manifestation, most commonly in the form of plasmacytoma, is seen in about 9.4% of those patients at initial presentation, which increases to almost 14.6% when they relapse. And this is quite higher than those reported in the Western population, probably because of the late referral and late initiation of anti-myeloma therapy in our patients. At a median follow-up of almost 24 months, we have almost 71.1% of those patients who are being alive and being followed up in our myeloma clinic. So after describing the clinical profile, the next domain of the disease that any treating physician or hematologist would be interested in is its immunofixation profile and risk staging, because it dictates the prognosis and therapy monitoring. So accordingly, the most common immunofixation profile is IgG disease, kappa followed by lambda, and then light chain disease, and then the least is by IgA disease. We do risk stratify these patients into low, intermediate, and high on the basis of albumin and beta-2 microglobulin once, but now with the incorporation of cytogenetics, we are better able to risk stratify these patients and initiate anti-myeloma therapy. One could see here, intermediate stage patients are the most common category of risk category that we commonly encounter in our department. So these are some of the rare and interesting cases that we encountered in our department. In the upper panel, one could see the predominant skeletal manifestation of multiple myeloma in the form of a solitary plasmacytoma, a thoracic plasmacytoma, a plasmacytoma of the knee. And in the lower panel, one could see the visceral manifestation of plasma cell disorders in the form of a thyroid plasmacytoma and a pancreatic and a mesenteric involvement by a case of plasmacytoma. So whenever a newly diagnosed case of multiple myeloma presents to our clinic, so we are interested in classifying the patient as transplant eligible or transplant ineligible. So this is based upon three main domains like age, ECOG performance status, and their comorbidities. So once they are deemed transplant fit, they go in for a triplet induction on a basis of 3 combination chemotherapies like bortezomib, and IMiD, and dexamethasone. And nowadays we are also adding monoclonal antibodies. So once after giving 4 cycles of induction chemotherapy, we collect the stem cells and proceed with an autologous stem cell transplant to achieve a good remission in those patients. But autologous transplant is the standard of care for any transplant eligible patients, and then followed by a maintenance strategy. If a patient is deemed transplant non-fit, then he typically gets almost 6 to 8 cycles of induction chemotherapy followed by a maintenance. So always one should remember that treating multiple myeloma is like a marathon and it is not like a sprint, because this is a disease which is characterized by active disease course and then a remission and multiple relapse course. So we have to reserve drugs till to the maximum so as to gain a good amount of progression-free survival benefit. So as I already said, the first line chemotherapy that any multiple myeloma patient will receive is a combination of 3 agents. First is a proteasome inhibitor, which typically attacks the myeloma survival pathway, and second is the IMiD therapy, that is immunomodulator like thalidomide or lenalidomide, which basically modulates the immune microenvironment, and third is dexamethasone, which again is toxic to the myeloma cells. So accordingly, the most common induction regimen that is followed in our department is VRD, which is a combination of bortezomib, lenalidomide, and dexamethasone, followed by VCD, particularly in those patients who have a renal impairment at baseline, because in those patients lenalidomide needs dose adjustment. VTD, that is incorporation of thalidomide, has taken a backseat, probably due to the increased incidence of higher incidence of neuropathy and suboptimal rates which compared to the lenalidomide. These doublets, that is combination of lenalidomide dexamethasone and cyclophosphamide dexamethasone, again are used only in those patients who are highly unfit for undergoing active chemotherapy. And with the inclusion of newer monoclonal antibodies in therapy, now we had started using anti-CD38 antibody, that is daratumumab, in some of our patients, which is helping us to achieve a good amount of molecular remission. Once after the induction chemotherapy is started, we do assess treatment outcomes in terms of a hematological response, in terms of a M band reduction, and then a renal outcome, how much degree of creatinine the patient has improved. So first is the degree of M protein reduction, which is defined according to the International Myeloma Working Group response criteria. Here one could see those response in those patients with renal impairment and those without renal impairment. And ideally one could see in those patients without renal impairment the degree of very good partial response, as defined by almost more than 90% reduction in M protein, is quite higher in those patients without renal impairment, and comparatively it is less in those patients with renal impairment, probably because of the non-permissive clinical situation where we are not able to deliver full dose of chemotherapy to those patients who are presenting with renal impairment. And accordingly, the degree of progressive disease is also high in those patients with renal impairment. So apart from the hematological response in terms of M protein reduction, we also are interested in renal outcomes in multiple myeloma. So out of those 220 patients who had presented with renal impairment at baseline, 15.4% of those patients needed a dialysis at a baseline. And after initiation of multiple myeloma therapy and a stringent renal replacement therapy, the median time to renal recovery was almost 19.8%, and the overall renal response was almost seen in 62% of those patients, with complete and partial response seen in almost 65 and 34.5% of those patients. And even after initiation of anti-myeloma therapy and adequate renal replacement, almost 10.9% of those patients only had turned to be dialysis dependent. So we all know that myeloma is a disease of elderly, but we do also encounter myeloma in young patients, as defined by less than 40 years in multiple oncology groups. So in the young, the predominant manifestation is hypercalcemia, and the striking feature is, even though with the increased incidence of light chain myeloma and a very higher risk stratification, these young patients had a higher survival rate, probably due to the absence of comorbidities and a better tolerance of chemotherapy. So, and nevertheless, whenever we are treating any young patient, we are interested in some specific issues like parenting and childhood. So once a disease of cancer is never an obstacle to successful motherhood. So once we encounter myeloma in any young patient, so we need to aim at achieving a good disease remission and plan successful pregnancies during the maintenance therapy, where the interference with drug involvement is the least to the patient. So with this, I next invite my dear friend Dr. Archit to continue with the transplant data.
Good morning. Continuing from where Dr. Gopinath has left, we'll discuss about the ASCT results of our department. In a span of past 5 years, we have conducted about 22 transplants, and despite the COVID, the number is further increasing. The number of transplants conducted upfront was 14. In the relapse refractory criteria, it was 8. In terms of division of number of transplants divided by age, the most number of transplants were conducted in the age group of 51 to 60 and 41 to 50. The risk group was the most common risk group, was the low risk, followed by the intermediate risk, and then the high risk. Post-transplant, these are our survival curves. We are getting almost event-free survival of about 72 months, that is 6 years, with a median overall survival of about 81 months, which is a pretty decent number, understanding the natural history of myeloma, that the disease is going to come back again. One of the major logistical issues which we face is for the management of these adverse side effects, which are a part and parcel of any transplant program. So these are basically grade 4 mucositis, nausea, vomiting, febrile neutropenia. We do get some amount of engraftment syndrome, some delayed platelet engraftment. Usually GVHD as a manifestation is seen more common in allogenic transplants. However, we did get to see one patient who presented with large volume small bowel diarrhea, and had a negative infectious workup, and had grade 4 GVHD, and needed a prolonged infusion of steroid therapy for the same. 3 patients needed a granulocyte infusion to tide over the crisis. One patient succumbed. Taking over to Waldenstrom's macroglobulinemia and our departmental experience. So Waldenstrom's macroglobulinemia is a IgM monoclonal gammopathy. It is characterized by bone marrow infiltration with a lymphoplasmacytoid type of cells. They have an intratrabecular pattern and a characteristic different phenotype from that of multiple myeloma. This is our 5-year data. We had about 26 patients. What is important in this whole 2 tables is that we need to understand that organomegaly, lymphadenopathy, and a normal renal function are more hallmark of Waldenstrom's macroglobulinemia as compared to myeloma, wherein renal presentation is predominant around 60%, and organomegaly is unusual unless it is poems or any other paraneoplastic manifestation. The third important manifestation which we need to remember is hyperviscosity syndrome, which can lead to a married manifestation like cryoglobulinemia, peripheral gangrene, or CNS manifestations. Of our 26 patients, 17 patients did receive therapy for Waldenstrom's, because anemia, splenomegaly, and hyperviscosity are the only indications. Other patients may be followed up. Considering the overall response rate of our patients was about 76%. As we note in the table, most of our patients did achieve a VGPR and less CR as compared to myeloma. And the 2 treatment regimens which we use predominantly were rituximab based and cyclophosphamide with rituximab and bortezomib. The survival curve on our left shows the survival with respect to the risk stratification for Waldenstrom's using a prognostic stratification system. Our data is in line with the IPSS score, and is fairly the score is fairly validated for our system. The survival curve on the right shows the difference of survival between the 2 chemotherapy regimens. We need to note one thing, that bortezomib based regimen is good for providing good initial response. RCD, a rituximab based regimen, is a gentler regimen. So even though it may have some lesser degree of complete response, however, the patients tolerate the therapy and have a better overall survival. So our this is a paper done by our senior colleague Dr. Sujit with Dr. Sanjeev, and we had a 5-year overall survival of 86% in patients with rituximab based therapy and about 60% in patients with bortezomib based therapy. Something about AL amyloidosis. Over a period of 5 years, we have encountered 18 patients, slight male predominance, about a mean age of about 54 years. The predominant manifestations included edema, proteinuria, renal insufficiency, peripheral neuropathy in about 17%. The other clinical manifestations included anemia, macroglossia, diarrhea due to autonomic involvement. About amyloidosis, we go about the diagnosis of amyloidosis when we have more than 2 organ involvement with demonstrated of amyloid deposits and further stratification of amyloid protein. The amyloid protein, we get a surrogate idea whether it is related to a plasma cell related process or secondary to a chronic inflammation process. So on based of the systems involved, we had about 80% of patients who had biopsy proven amyloidosis. About 28% of the patients had cardiac involvement. typically severe type 3 diastolic dysfunction. 17% of the patients had both cardiac and renal involvement. Now, a staging system was evaluated in Mayo Clinic in 2012, which makes the use of NT-proBNP, cardiac TROP-T or TROP-I, and difference in the free light chain assay, which helps us give a very good idea about the overall survival. The overall prognosis of stage 4 amyloid is very poor, with median survival of less than 1 year. So we had about, predominantly our patients had manifested in stage 3 and stage 4. The therapy of choice in these patients, as told by Dr. Faima, is treated towards the treatment of the plasma cell clone. So most common in view of renal impairment, we do end up treating them with a VCD based regimen. In terms of normal renal function, we give a VRD. One patient progressed from VCD, so we did try to salvage the patient with a daratumumab based regimen. As these patients have a poor immune response, they have a tendency of gram-negative sepsis, and we had 33% mortality attributed to gram-negative sepsis. I'd like to request Dr. Sanjeev sir to take over from here to give the future insights.
In last 5 years, we have tried to give facilities to our myeloma patient by providing them a dedicated myeloma OPD on Friday. For correct risk stratification of our myeloma patient, we have developed in-house FISH panel, which is a very uncommon for a government setup to have an in-house FISH facility. And with that, we are able to correctly risk stratify our patient and take aggressive measurement for induction and transplant for those patients with high risk FISH. We have also established minimal residual disease assessment, which is unlike any other hematological malignancy, a very important tool for response assessment, especially patient undergoing transplant, because with MRD positive patient undergoing transplant, the transplant outcome are poor, and patient being MRD negative prior to transplant is very important for any kind of transplant. We have used upfront quadruple therapy with the arrival of approval of daratumumab by FDA in high-risk myeloma group, and able to salvage even double hit or triple hit multiple myeloma. Our department has got DBT grant for bispecific second generation CAR T cells, and preclinical studies underway for second generation anti-CD19 CAR T cells. This will help to establish a CAR T cell program for relapse refractory multiple myeloma patient in future. What makes SGPGI an ideal myeloma treatment center? As I already discussed, we have a dedicated OPD. Our nephrology department gives 24/7 dialysis services. Myeloma FISH panel and minimal residual disease assessment is available in-house. We have a dedicated myeloma lab and molecular hematology lab, in which we have a possibility of all molecular tests in-house. Our blood banks give 24/7 hour support for blood product transfusion. We have facility for low dose CT, which is an initial evaluation for myeloma patient, and also for extramedullary disease manifestation, we have PET CT facility. We have autologous stem cell transplant for myeloma patients, and we regularly do autologous stem cell transplant for myeloma. We have a pain management facility provided by Pain Clinic, which is fortunately in the same OPD cubicle of hematology, and patients who have permanent damage to vertebra due to myeloma, we have facility for vertebroplasty or kyphoplasty, which is provided by intervention radiology. We have these notable publications in various reputed journals. We have also presented our data in various national and international forums. This is the Indian Myeloma Congress. Our students have won first prize in 2020 in National Myeloma Quiz. In 2021, we have organized the Indian Myeloma Congress, and our students have won the first prize in poster presentation. There is a Indian Myeloma Academic Group in national level, and all the patients are registered on online portal by Care for Myeloma. We are at there. From last year, we have joined there and we have a presence there. In future, we are planning to having a comprehensive myeloma clinic in which a collaboration of nephrology, orthopedics, hematology, and pain clinic can give a solution to our all myeloma patient in a single roof. We wish to have a whole body MRI facility and mass spectroscopy facility for amyloid subtyping. We will also planning to do tandem transplants for very young myeloma patients. We will love to have part in international drug trials and cellular therapy and CAR T-cell therapy on board. My sincere thanks to our patients, our dedicated nursing team, Department of Nephrology, Department of Neurology, Department of Endocrinology, Department of Pathology, Department of Radiology, Department of Nuclear Medicine, and Department of Transfusion Medicine. Thank you.